Welcome to this video on facet joint intervention techniques. This is specifically done for the RADICAL study, which is a randomized control study looking at facet joint innervation for the treatment of low back pain. I'm Dr. Ganesan Barnidharan. I'm one of the pain consultants at the Leeds Teaching Hospitals, and I'm part of the RADICAL study team. So the technique that we're going to use for the radiofrequency innervation was designed by Dr. Shardul Nath, and most of you are probably well aware of him. And I'm going to try and go through this technique. And some of the slides are kindly provided by Dr. Nath and some of my own images. In the next 15 to 20 minutes, I've decided to do this video in 2 or 3 parts to really make it easy for people to go through. In the first part, my plan is to just cover the relevant anatomy needed for the facet medial branch block and RF. Why do we use curved needles? How do we perform facet medial branch block, and what are the pitfalls? And then also, how do we assess the facet joint RF block followed by radiofrequency technique? Facet joint pain is normally worse in the mornings, and they tend to have unilateral or bilateral paravertebral tenderness. They can't sit for long, can't stand for long, and bending backwards provokes the pain. They like to move around, and that normally makes them feel better. So at this point, you would suspect a facet joint pain, and this is when they are taken through the nice pathway for a facet medial branch block as a diagnostic tool. General rules: for a medial branch block, you want to be more lateral and more superior, whereas for a lumbar RF, you want to be less lateral and more inferior. So what does this mean? I mean, this is what it means. If you are more lateral as your starting point, you can get into the medial branch block, which runs in this groove between the superior articular process and the transverse process. For doing an RF, as you need to place the needle parallel to the nerve, you want to come as medial as possible, but also inferior. If you're too medial, remember this pedicle will push you out, so you would miss the target. If you're too lateral, you would miss the target too. So you want to be in an ideal curve where you're as medial as possible and as inferior as possible to get into the groove. One of the key structures that you need to remember when you're doing facet blocks is the mammulo-axillary ligament. This is a ligament which connects the mammillary process and the axillary process. And the medial branch runs underneath this groove. So if you're not underneath the mammulo-axillary ligament, you will miss the nerve. So this is how it looks. This is just a dissection picture showing the medial branch. In this particular, there's an aberrant of 2 medial branches in the same patient. And that's the mammillary process, and that's the axillary process, and that's the mammulo-axillary ligament. Again, this shows pictorially in your Scotty dog view where the mammulo-axillary ligament is. And some of them have completely calcified ligament in some older patients. So the next thing to remember is the nerve runs in the groove between the transverse process and the superior articular process, and we're trying to get to the bottom of this groove. And this would be useful for us because all the images that we're going to use is aiming at seeing this bottom of the trough. And this is a picture showing the medial branch running in the groove. And as you can see, the angle of the cannula, especially when you're doing the RF, you want to be downwards and medial. So our technique of as medial as possible and as inferior as possible gets the majority of the nerve that we are trying to generate. Scotty dog, we all know Scotty dog, and as you can see, that's a superior articular process, that's a transverse process, that's a laminar, that's a spinous process, and that's the inferior articular process. The teaching is always the eye of the dog is where the medial branch runs, but you also need to be careful because you can still put the eye quite lateral on top of the pedicle, which meant you would miss the medial branch when you're doing a radiofrequency, when you're doing a diagnostic medial branch block. So this needle, as you can see, looks reasonably well, but just one view is not going to help us to know whether this is exactly in the spot that we're trying to treat. So for example, here you can see, when you look at the Scotty dog, this position of the needle, or the pen in this case, would still look like the eye of the dog. But unfortunately, if you do an inferior view, you can see the target is way away from where the needle is. And hence, lateral and superior in the groove. And when you do an inferior view, you can see there's a U shape, and the needle should be in the middle of that U shape, which clearly gives you the perfect position for the needle placement for a medial branch block. So this is another example. As you can see, this is where the groove is, and we've got a needle position in the groove for blocking the nerve. And that's exactly an X-ray view at for the L5 dorsal rami. This looks a really nice position until you oblique it a little bit further, and you can see your needle is stuck on the pedicle of the S1. And you just need to push that needle in a little bit further to get into that groove where the nerve runs. And these are the things that you have to really be careful about. Once you get a satisfactory view, having an inferior oblique view would confirm your needle position. So a typical example, I'm quite happy with this needle placement. As you can see, that's the transverse process, of the superior articular process, and all my needles in an AP view looks reasonably in position. I then tilt the image for an inferior oblique view, so I'm looking at it from the bottom of the patient, and you can see the curvature. This is the transverse process, which then runs up to the superior articular process. It forms a U shape, and you can see the second U shape here, and a third U shape here, and a fourth V shape, especially when it comes to the L5 sacral ala. And this is a really well-positioned needle at the trough of the superior articular process and the transverse process, which meant we are sure that this needle is in the perfect optimal position for blocking the medial branch. This is another example of what the needle looks like. And as you can see, this needle is both the L4 and L3 are away. So L3 needs to be slightly inferior, L4 needs to be more lateral and inferior. And you need to adjust this to get into this groove and not be fooled by just one single view of the Scotty dog. When we use a medial branch block as a diagnostic tool, would you consider steroid? And I think it should not be used, as obviously steroids will confuse the issue here. We're looking at a diagnostic block, so we would like to use pure local anesthetic of your choice, either 1% lignocaine or 0.5% chirurcaine, bupivacaine, ideally a volume which is less than 1 cc. The patient is then given a questionnaire to take home where you would mention their first starting pain as 100, and I'm going to call this as a starting pain. And then as the time goes on, every hour on the hour, they just mark it for the next 6 hours, the day after, and a week after. And that gives you an idea. So in this particular patient, the reduction in pain is less than 40%. So I don't think we've either missed the pain generator or the facet joint is not the predominant pain generator in this patient. Whereas when we look at this patient where there is nearly 80 to 90% improvement in the symptoms for the first 6 hours, and then slowly the pain comes back, this is a typical positive response to a medial branch block. So in conclusion, for the medial branch block, try and be superior and lateral. Always don't rely on one view, which is a Scotty dog. Kindly get an inferior oblique view so you can clearly see the needle tip position in the groove between the spinous transverse process and the superior articular process. Use only local anesthetic, minimum 1 cc or less than 1 cc. There are some people who use contrast, but obviously if you mix the contrast with the local anesthetic, it's going to dilute the concentration of your local, to take that into consideration. And when it comes to levels, I would probably think blocking mode is better, because sometimes you have a patient where you just do one block, one level, let's say L5S1, and the question that comes back is they've got 50% improvement. The question is whether you actually covered all the areas of the pain generator, especially have you missed the L4-5 or L3-4? So blocking L2 to L5 medial branches would cover 3 joints, which actually gives you a better way of diagnosing if the pain is definitely coming from the facet joints or not.